Respected chair and delegates, wish you all a very good morning. I would like to thank AIOCMTC Scientific Committee for giving me this opportunity. So today I'll be discussing about one of my studies, that is a corneal tomography in fellow eyes of unilateral keratoconus for detection of subclinical keratoconus. So I have no financial interest. So studies suggest that subclinical or clinical keratoconus is found in 1 to 6% of the myopic patients undergoing refractive surgery. And as we all know, advanced keratoconus can be diagnosed with clinical and tomographic findings. However, detection of the disease in the preclinical stage is difficult. So this is a pictorial representation which shows the terminologies keratoconus suspect, forme frucea, and subclinical keratoconus, which often are overlapping terminologies. So as you can see in the diagram, the subclinical keratoconus actually includes both the forme frucea and the keratoconus suspect. So you can see a cutoff there, which is actually the tomographic cutoff. So keratoconus suspect can be defined as those with some tomographic changes but not with any clinical findings, whereas forme frucea keratoconus is basically an incomplete or distorted form where there may not be any tomographic changes, so neither tomographic changes or nor any clinical changes. So basically it is very difficult to detect a case with forme frucea keratoconus. So the purpose of the study was to analyze the tomographic changes in fellow eyes of unilateral keratoconus patients by comparison with normal eyes. This was a time-bound 5-year retrospective observational study, and patients with unilateral keratoconus were diagnosed by pentacam, and normal candidates for refractive surgery were included as controls. The ethical committee approval was obtained, and the study subjects were divided basically into 3 groups. The first group had 15 advanced keratoconus eyes with unilateral keratoconus, and second group with the fellow eyes of those unilateral keratoconus patients, and the third group were normal refractive surgery candidates. And now the highlighting point is that the fellow eyes didn't follow even one criteria on the pentacam, that is even the final D value less than 1.6 from the bad value was included. Exclusion criteria included any history of ocular surgery, trauma, any pathology of significant corneal scarring, and the examinations were performed using a pentacam rotating shim flip camera. All the data from the pentacam maps, that is including topographic, elevation, topometric, and bad maps, were analyzed. These are the statistical methods used. We have used a chi-square test followed by a one-way ANOVA, and an ROC curve with area under curve was used for distinguishing the parameters, and an area under curve more than 0.7 is considered as significant for diagnostic specificity and sensitivity. So 64 eyes of 49 patients were analyzed, and the keratoconus manifested mainly in males and basically in left eyes. The mean age was 26 in unilateral keratoconus group and 25 in the normal group. So these were the 5 parameters which were found to be very significant between the fellow eye and the normal group. That is the corneal thickness at the apex, the thinnest point of the cornea, the corneal volume, bad thinnest point, and thinnest point displacement. This is the ROC curve, and from the ROC curve we have got these 4 parameters as the significant ones with an area under curve more than 0.7 for distinguishing subclinical keratoconus. However, as you can see, the specificity of all these parameters are very low. D value and pachymetric progression index maximum were the most characteristic indices in discriminating fellow eyes with normal eyes, similar to the studies in literature. However, this study is the first study in Indian population to identify the changes in the fellow eyes of unilateral keratoconus patients. We have a few limitations. The main limitation is the small sample size. However, it might be due to the rare incidence of true unilateral keratoconus. Further studies with larger sample size and simultaneous evaluation of corneal biomechanics and wavefront aberrations may be more useful. To conclude, bad D value and pachymetric progression index were more effective than other pentacam parameters in detecting the earliest form of subclinical keratoconus. This study also highlights the usefulness of shim flip imaging and not a single parameter. However, we need a combination of different data to distinguish subclinical keratoconus.